Welcome to the Health Management Academy. In part one of the patient experience, we'll be looking at input and throughput concepts.
In the ever-increasing complexities of healthcare and drive for efficient use of resources, all organizations must focus on the patient's continuum of care throughout the hospital experience. This includes entry into the organization, input, appropriate and efficient care during the stay, throughput, and a successful transition to the next appropriate continuum, output. Hello, I'm Lori Ramsey, Chief Nursing Officer from Crossgates River Oaks Hospital. We are talking about benefits of an effective patient flow and discharge planning program. As part of an evidence-based approach monitored on a monthly basis through the patient flow and resource management scorecards, the pair will have far-reaching advantages to patients, staff, and hospital operations. While the main purpose is to improve input, throughput, and output, the benefits to a successfully implemented program will improve the patient experience throughout the continuum. The examples you're about to see can easily be implemented in your hospital and will lead to greater efficiency through effective interdisciplinary communication along the continuum. Let's take a look at the patient experience in action.
Good morning, Rose. Do you have time to review our patient list this morning to make sure we're continuing to move forward?
Sure. We had 2 new patients admitted last evening, both with chest pain. Both are on telemetry, and that fills all of our telemetry beds at this time. One is an undocumented immigrant. With his history, I'm sure he'll be a challenge in this afternoon's meeting. He's homeless and he has a polysubstance problem.
Okay, I'll review his case first thing this morning and get the social worker involved if necessary. After reviewing my list from yesterday's meeting, I have 3 potential discharges by 11 and 9 other potential discharges.
Here, the charge nurse is filling in the case manager about overnight changes so everyone can work toward the goal of discharge by 11. That's the patient flow metric that determines if we've met expectations.
Room 231 is going back to the nursing home today via ambulance at 9 o'clock. I've already notified the family of what time he's going to be arriving back at the nursing home. His chart's been copied and it is in the back of the hardcover chart at the desk. Room 242 is going home today. We've set home health up for her and they should be coming out to see her after lunch tomorrow. If she doesn't go by 11, please call me, as I need to let the home health agency know. And also, I couldn't tell by looking at the chart if the required core measure congestive heart failure education had been done. And so I put the standard education in the chart for the primary nurse.
Okay, I'll be sure that Susie takes care of that first thing.
Okay, great. Room 244 is also going home today. They've been set up for outpatient physical therapy and her DME should be arriving in a minute. Do you know of any other discharges?
We have 1 other discharge at this time. Mr. Rogers is going home. I've looked at your note and it doesn't appear that he has any needs.
Okay. I'll double check with him to make sure nothing's changed before he goes home. Were there any issues in report that I should know about?
Ms. Moore had a stroke last evening and she's now in the ICU. Ms. Williams and 2:30 was to have a stress test last evening, and so she could be discharged this morning, but it was canceled because of another emergent situation, and it'll be rescheduled for this morning.
Okay, it sounds like we have an avoidable day that needs to be assigned to the cath lab, and I'll follow up with Mrs. Moore as this will change her discharge plan.
Okay.
This is so helpful. Knowing patient volume is key to patient flow. Who is being discharged and when? Also, highly likely admissions to inpatient units. This is how to achieve efficiency in bed placement.
Crossgates River Oaks.
This is Crossgates. Go ahead.
We have a 54-year-old male patient. He is unstable with chest pain times 12 hours. He's 9 on a scale of 10, who is diaphoretic. No allergies, history of smoking, blood pressure 90/60, pulse 62. He's showing sinus rhythm. Respirations are 24, temperature is 99.6, pulse ox is 92% on 6 liters of O2. He's received nitro × 3 sublingual aspirin 1 PO. Our ETA is 5 minutes.
Nothing further. Crossgates clear.
Unit 154 clear.
We need to call bed control and get a bed for this patient.
How soon should bed control be notified of a potential admission? As soon as the information is received about the potential admission coming into the ED. And that is just what she does.
Hi Kim, this is Missy down the ER. We have a patient with acute chest pain coming in. We will place him in our only available critical care bed in the ED. Thank you.
Good morning. I know that we're full in ICU, so I'd like to get started there. So tell me where you're at, Glenda.
Welcome to the bed huddle meeting, where bed control is in process. After responding to the ED, the leader facilitates the bed meeting, going over all the roles of all disciplines, particularly EVS, in-bed flow, and methods of tracking.
We started with 7, we had 1 death, we've got 2 patients going out to telemetry, and we have 1 patient actually going home.
Okay, Keisha, how's your ER doing? Do you have anything?
Right now I'm going to need that ICU bed. We just got a critical care patient and cardiac patient who we don't think we're going to transfer out, so we're going to need that bed. Yesterday we saw 79 in the ED with 2 LWATs and 1 AMA, and our average time to floor yesterday after the bed was assigned was 23 minutes, so that flowed pretty good.
Good. Stacy, how are we doing on med-surg?
We have 3 beds right now.
Okay. Katie, how about telemetry?
24 were full.
24. Anybody coming off?
No.
No coming off. How are the AM turnarounds with the labs this morning?
We're 100% compliant.
Woo, girl.
15
6:30. Yay. 6:30 turnaround time. Good. X-ray, did we read?
AM film's okay. 31-minute ER turnaround time for techs and 14-minute Dr. D rad signing.
Okay. How was the OR cut time this morning?
We did not cut at 7:30. One of our doctors cut at 7:42. The other one 7:45. We had a difficult intubation, and one of them 8:22. The doctor was late.
Okay. Any AM admits?
We have 2 AM admits and 1 observation and a possible med surge.
Okay. Kim, how are we doing overall on the beds?
We will have 2 ICU beds available, 3 med surge, and no telemetry beds. What about EVS?
We're fully staffed.
Okay. Carrie, how about do anybody transfer out to facilities or anything today?
Yes, I have 1 that'll go by 11 o'clock this morning and 2 possible discharges today.
Okay, well, you work on the potential discharges with your resource managers today, and then y'all work on the flow, and then we'll meet back again for discharge planning at 1.
Yes.
Thank y'all.
Thank you.
The keys to bed flow throughout the throughput process are communication, communication, communication. Detailed. When are patients leaving? When will surgeries be completed? Thorough, discussing all units. Timely, up-to-the-minute information. Open, communications. When is one bed truly available and ready for another patient? Hourly rounding, so you always know what's going on. Okay, good. The ED nurse and the CNA are with the patient, checking vital signs, performing the assessment, and entering orders in the bedside computer. For effective patient flow, consider these important elements: a quick yet thorough assessment, collaboration with all disciplines, the importance of technology, and registering and documenting information at bedside.
Mr. Campbell, I'm going to be doing a complete assessment on you. There are going to be people coming in doing lots of things. The laboratory's going to come in, draw some blood. There's going to do a chest x-ray, and we're going to do an EKG, okay? How's your pain right now on a scale of 1 to 10?
It's about a 6.
About a 6? Okay. Well, I'll finish my assessment, and then I'll go get you something for pain, okay?
Thank you.
Okay.
Now the ED nurse is discussing the patient with the ED physician.
Is this the patient EMS just brought in?
Yes, sir. It's Mr. Campbell. He's a 54-year-old male having substernal chest pain for about 12 hours. His vital signs are stable, and his pain level is a 6.
Great. I don't see any current of injury, but let's go see Mr. Campbell.
Yes, sir.
In ED, an assessment of chest pain includes these important elements: vital signs pulse oximetry, history and charting in ED room, 12-lead EKG and monitoring, as well as cardiac enzymes profile.
Hello, Mr. Campbell. I'm Dr. Cook. I'm your emergency physician. I'll be taking care of you, and I'm going to need to do an assessment. But before we start, when did this chest pain occur?
About 12 hours.
Okay. What were you doing when it started?
Running.
Okay. Where is it located?
In the middle of the chest.
Middle of the chest. Is it moving anywhere at all?
No, sir.
Not at all. Any shortness of breath?
Yes, sir.
Okay. Have you been nauseated at all?
No, sir.
No. Okay. Any allergies?
No, sir.
Okay. And
No, sir.
is there any family history of cardiac problems at all?
No, sir.
And how about yourself? Any prior
No,
history?
sir.
No. Okay. Deep breath. Good. Deep breath. Good. Teresa, since his blood pressure has improved, let's give him 2 milligrams of morphine sulfate intravenously, and let's hang a nitroglycerin infusion at 90 mics a minute.
Yes, sir. So we're going to give morphine 2 milligrams IV and a nitroglycerin infusion at 90 mics per minute.
That's correct.
Yes, sir. Okay, Mr. Campbell, how's your pain now on a scale of 1 to 10?
So 1 or 2.
Okay, well that's good. We're going to be moving you to a critical care bed, and then Dr. Benson, the hospitalist, is going to come in and talk with you, okay?
Okay, thank you.
Welcome back. Here's how the next part works. We'll show you the different parts of the process, and you'll see the title on screen. Now, by the time we're done, the first letter of each will spell out I pass the baton. Now, this little exercise will make it easy for you to remember all the steps. Are you ready?
Mr. Campbell, this is Angel. She's going to be your nurse here in the ICU until 7 o'clock tonight, okay?
Hello, Mr. Campbell.
Mr. Campbell's a 54-year-old male. He came in by EMS to the emergency room about an hour and a half ago. He's been complaining of the chest pain for about 12 hours. His vital signs were blood pressure 90/60, pulse 92, respirations 24, and the temp was 99.6. The EKG shows sinus rhythm with sinus bradycardia and inverted T waves. The 12-lead EKG revealed recent MI and inferior ST depression and inverted T wave. He had 6 milligrams of morphine down there and nitroglycerin 3 times sublingual. We started a nitroglycerin drip, and it's now at 90 mics per minute.
Okay, what's his current situation?
Mr. Campbell has no known allergies. Bed rails up, call light is in reach. He knows not to sit up without assistance. History of hypertension and CAD. His medications include daily baby aspirin, low pressure for his blood pressure, and nitroglycerin for his chest pain. He's married and has 2 grown children and 3 grandchildren. He stopped smoking 3 years ago, and he does not drink. He weighs 136 pounds. Mr. Campbell had an EKG, a chest x-ray, CBC, lights with enzymes, and with the troponin level in the emergency department. His troponin level was 1.6, the CKMB was 7.5. The EKG showed the ST depression and the inverted T wave. The chest x-ray was normal. We started him on the nitroglycerin drip and titrated it for pain, and it's currently at the 90 micrograms per minute. And his blood pressure is holding at 90 systolic. Got the heparin drip going at 1,250 units per hour, and we gave him a 5,000 IV bolus before we started the drip. The next enzyme is due at 6 o'clock and the PTT at 4.
Okay, I'll be sure to check on that.
And his wife and children are in the waiting room, and Dr. Cooler, who's the cardiologist, has been called in to see him.
Okay.
And then Dr. Benson's the hospitalist, also saw him in the emergency room.
Okay, well, what's next for Mr. Campbell?
Just to continue to observe him for chest pain and possible scheduling for cardiac cath.
All right, Mr. Campbell, we'll take good care of you back here. One thing I want you to know, we've got a plan of care up here, and that's just, I want to stress you what's important for you to know. Your pain control, we need to know if you have any pain, let us know. We'll have you on a monitor continuously. That way we can see if there's any change in rhythm whatsoever. We're going to keep you on your oxygen. And if you do have chest pain, we may call in the respiratory therapist to come in here and do an EKG. Here's your call light. If you have any pain, any shortness of breath, you call me, okay? All righty.
There you go. Introduction, patient, assessment, situation, safety concerns, the background, actions, timing, ownership, and next steps. I pass the baton is the smooth transition from input to throughput. Sure, you've been educated in this process before, but it's always good to review something so vital to patient flow. And when you follow each of these steps, it's better for the patient and easier on all staff. Stay tuned for the next video where we'll focus on throughput.